All right, everyone. We're going to get started with our next session, which is titled Therapies That Slow Progression. So just as we're kind of thinking about this, some of the talks that we had day kind of 1 and 2 when we were starting to discuss some of the investigational therapies, a lot of that was focused around strategies to kind of restore or replace dystrophin, either through the gene therapies or the exon skipping. What we're going to talk about in this session are some therapies that are looking at kind of other aspects of Duchenne that we can maybe target to help slow disease progression. In your booklet that kind of talks through the different investigational trials that are ongoing, you'll see a little kind of graphic in there that kind of has this cascade of when you are missing the dystrophin protein, all of these other things that come along with that. A lot of these are therapies that kind of can help tackle some of those issues and help kind of impact disease progression. So we're going to start with a talk by Dr. April Pyle from UCLA around cell therapies, because that's something that, similar to gene therapy sometimes, it's kind of this umbrella term that we use, and so we wanted to take a little bit of time and just kind of unpack what some of these cell therapies are, kind of what they can be, what they represent for potentially for Duchenne. So I'm going to invite Dr. Pyle up to help talk us through some of that.
All right. Thank you, Eric. And I want to say a special thanks to you, Eric, for organizing this and for PPMD for putting on a fantastic meeting and getting us all here today. So yeah, as Eric mentioned, what I'm going to do today is really just kind of give you some background information on mainly stem cells, and also there'll be some other cell types in there, just to kind of define what they are, what are the differences, and where are we today, what have we learned. Okay, there we go. All right, so just kind of starting with, what everyone's sort of question is, what is a stem cell? And this is really a broad term, so what I'm going to do is walk you through different types of stem cells, and then I'll go deeper into muscle stem cells. But in general, a stem cell is a cell that really has potential to give rise to more of itself, and so this is a process known as self-renewal. And so this is something that a stem cell can do, but also can differentiate or give rise to a different cell type, a differentiated cell, and some of those are shown here. And the potential of stem cell research really, over many years now has kind of evolved to be many different things. And so in the lab, we use stem cells as a tool to understand many different things, such as how these cell types arise in the body, developmental biology, how to make specific cell types in a dish in the lab, and more specific cell types that I'm going to talk to you about, human-induced pluripotent stem cell-derived cardiomyocytes, as well as skeletal muscle, are being used in preclinical settings for drug discovery-based research. So the cool thing about this is that we're working with human cardiomyocytes or human skeletal muscle. In addition, we can use these as a tool to understand how these drugs work in human cell types. And then finally, there is a lot of excitement about the potential use of stem cells in cell-based therapies. So I'll tell you some of the pros and cons, really where we are in that area today. So there's really two main types of stem cells. There's what are called embryonic stem cells and adult stem cells. Embryonic stem cells are typically called pluripotent stem cells, and this is because they have the ability to give rise to most all cell types in the body. They can grow continuously in culture, and they really are a cell type that can be expanded indefinitely, and this is really an important avenue or use of these cells because they have that ability to continuously divide in a dish. But the challenge is that these stem cells, because of their nature, they're embryonic, they actually can form what are called teratomas. if they're not 100% differentiated. And so when you're talking about a pluripotent stem cell in the lab, we're always trying to differentiate them into specific cell type like cardiomyocytes or skeletal muscle. But if there are still pluripotent stem cells left behind, they will form tumors. And so this is something that is continuously being monitored and evaluated, like how do we continually push them to differentiate 100% into that cell type. And so I would say the methods to differentiate these cells are less well understood than adult stem cells. So adult stem cells are something like a muscle stem cell, which you're all familiar with, heard a lot about at this meeting. These are considered multipotent, so they have less potential, so they are specifically differentiating into that specific muscle. So skeletal, for example, into that specific tissue. So for example, a muscle stem cell makes skeletal muscle new myofibers. So these have less potential, but they're very well studied. So a lot of what we know about stem cells has occurred through studies of hematopoietic stem cells, which are the gold standard blood stem cells. So these give rise to all of the immune cells, all of the cells in the body that are blood-based. And then there are mesenchymal stem cells that are also less limited in their potential. And typically these are used for things like providing immunomodulatory or survival factors. And then as I mentioned, the muscle stem cells are a true stem cell in the skeletal muscle that upon injury can give rise to new fibers. These are actually very rare in the skeletal muscle. So if you look at a cross-section of skeletal muscle, you will only see one or two at any given region. And so they're very rare cells, but very poised to do their job, which is to make new fibers upon injury. However, in a contrast to pluripotent stem cells, these are very difficult to isolate because there are so few, and they're difficult to expand and maintain as stem cells. And so there's still a lot of exciting research on understanding how to maintain these as stem cells. And I would say that, as I mentioned, a lot of our knowledge about what we know is based on the gold standard hematopoietic stem cells, although there are a lot of different nuances depending on the stem cell populations that you're working with. So I think it's important to note, because this has been controversial in the field, that the heart does not have an endogenous stem cell. And so strategies for repair in the heart would be very different than in the skeletal muscle. So a lot of different strategies have looked at providing survival factors, something that could give rise to transient or immunomodulatory effects. And so there's different companies and a lot of different research labs looking into things that might secrete survival factors that could help support the heart, as you heard from Eric, sort of lessening the damage that's occurring over time. And so this is something that wouldn't be a cure, but could be combined with other disease-modifying therapies, potentially. But skeletal muscle, as I mentioned, does have an endogenous stem cell called the muscle stem cell. And this sort of cartoon kind of depicts the biology of what's happening upon injury. And so, as you can see here, you have a multinucleated myofiber, and then you have a stem cell that's called a satellite cell sitting on the outside of the fiber. Upon injury, this cell will get activated. It will then begin to express genes that are important for telling the cell, okay, now it's time to make new fibers. And these activated cells will then go on and make the multinucleated cells of the fibers. And so you can see in this cross-section of fibers, upon injury, you can see that there's a process of multiple cells, actually not just the stem cell, but other cells in the environment that are cross-talking to the stem cell that help that process of repair. So it's a multifaceted process, but you can see by 30 days there's a complete repair in that region where there was injury, and this is I believe this is actually a mouse model, with mouse muscle stem cells in this cartoon. Oh, and these are those factors that I was telling you about. So we look at muscle stem cells with the marker PAC7. This is a key marker that defines the stem cell. And as they become activated, they turn on other transcription factors shown here. Now, there's a lot of interest, and there's been a lot of amazing work, groundbreaking work by many different stem cell labs. Michael Rudnicki, as you heard about earlier, has done amazing work looking at, what really regulates stem cell behavior. And in mouse models, he has really pioneered over many years understanding genes that regulate this process of stem cell activation, stem cell self-renewal. And so there's a lot of interest in trying to understand, can we use perhaps small molecules, which he has shown in many different research papers, to modulate the stem cell state in skeletal muscle. And so his group and many others are looking at drugs that can specifically modulate the stem cell state to better support regeneration, such that if there's a process whereby which the stem cell gets stuck and not able to make new fibers, perhaps we can guide it along to support better regeneration. So this is, I think, an exciting new avenue to watch out for, still very early. Another very early, I'd say up-and-coming strategy are the potential use of human-induced pluripotent stem cells, which you've probably heard about from groundbreaking work from a scientist in Japan, Shinya Yamanaka, who actually took 4 genes, put them into a cell, any cell in the body, really. You can put them into fibroblasts, blood cells. These being overexpressed in the cell can then differentiate into any cell type in the body. So this is a pluripotent stem cell, right? And so then the promise is, or the thought is, that we can differentiate these into cardiomyocytes or into skeletal muscle for both drug-based discovery, so patient-specific personalized medicine, or for potential use in cell-based therapy strategies. And another strategy that is ongoing is actually combining gene correction-based strategies, such as shown here, like CRISPR gene editing, into these reprogrammed pluripotent stem cells, then differentiating them into the affected cell type, cardiomyocytes or skeletal muscle, and then transplanting these back, hopefully someday, into patients to target individual muscle regions or the heart. And so, these are sort of different strategies that I've been thinking about. So we've, in fact, also been thinking about different strategies to pair stem cell-based strategies with gene editing. But the challenge really is delivery. And so, really, how can you support delivery to all muscle cells in the body? And so this is a challenge. And so still delivery of gene editing based strategies probably are the most effective with an AAV based strategy. And important to note that these studies with gene editing based strategies are just in preclinical studies and have thus far only been evaluated in animal models. And another challenge, as I mentioned, is that when you're thinking about delivering a strategy with a stem cell based approach, is that these cells really are not able to migrate to all muscles, and so you have to directly transplant them at the site of individual muscles. So this is very challenging to reach all muscles. So in the lab, we spend a lot of time thinking about ways to better support the stem cells. So as I mentioned, the stem cells can't be maintained with PAC7 on continuously, and so we're thinking about strategies to support the stem cells so that we can use them, in a more clinical-based strategy. And so this is a challenge, as well as getting them to reach multiple muscles, which is currently ineffective. So this is something that is one of the things that I guess is the grand challenge in stem cell-based therapies, which are listed here, are really thinking about how to keep these as true stem cells, right? So as maintaining their potential to both stay as a stem cell, but also make new fibers. Sometimes stem cells, specifically pluripotent stem cells, can become unstable in culture, and so we have to monitor their genetic stability over time. And then it's quite a challenge to get these cells, specifically, for example, muscle stem cells, generated in sufficient numbers and purity. And what is the right cell type for transplantation? The stem cell, the progenitor, terminally differentiated cell. And so these are all still ongoing strategies that are being evaluated. And then, as I mentioned, integration into the right place in the muscle is critical. And so we call this the home or the niche. And this is something that, especially for pluripotent stem cell-based therapies, is still being evaluated. And so a lot of folks are spending time trying to understand when you engraft these cells into muscle, where do they go? Can we track these cells over time, where they are engrafted? And so this is something that I think is going to become more and more exciting with new imaging-based strategies. So as I mentioned, these are a couple of challenges. So the muscle stem cells themselves rapidly lose their stem cell potential once they're isolated, and they become myoblasts. And this is fine because this is their job, is to continue on to make new fibers. But if you're trying to develop a cell-based therapy, you need to develop ways to keep these cells as true stem cells so that when you put them in, they maintain as a stem cell state and then differentiate there. So that's a long-term strategy that's been a battle in the field for many years. And as I mentioned, transplantation of these cells requires direct injection, and so they do not migrate systemically. So they are not effective at reaching all muscles. They are okay at engrafting where you put them in the fibers, but this means a cell-based therapy for reaching all muscles is challenging. And then also, depending on the state of the fiber that you put them in, this could actually alter how the stem cell behaves. And so this still requires, I think, a lot of ongoing work. And I'll just leave you with that. I think that there's a lot of promise, a lot of excitement for a lot of these new stem cell-based strategies that I've told you about, but it is important to be cautious and to really follow the right channels when you're thinking about stem cell-based strategies. So always go to the appropriate clinical trial site. Make sure that you're not, considering any stem cell-based treatments that are unproven. This would only worsen the trajectory, and please rely on your colleagues and get advice from your physicians, PPMD, and other trusted sources when you're thinking through this, because as I mentioned, stem cells is a broad term, and so you really want to know what's happening, what's been done, and make sure that this has been followed rigorous research, publications, with great teams, and this is really important. But I would say stay tuned. There's a lot of excitement about stem cells in the field, and so it's one of these ongoing new strategies. So with that, I think I'll leave you to Eric. Thank you.
Thank you, April. And then our next talk, we're going to kind of shift into discussing some products that are currently being investigated in clinical trials. And so first up from Riley Children's, I'm going to have Dr. Larry Markham come and join us to talk through the programs for Cumberland Pharmaceuticals and Capricor Therapeutics.
Thanks, Eric. So I have two components, as Eric mentioned. One is Cumberland Pharmaceuticals, and in the interest of full disclosure, I am a study PI for this program. So Ifetroban prevents fibrosis and inflammation by blocking thromboxane receptor signaling, which you can see in the cartoon is integral in the cascade of Duchenne and the pathways of inflammatory response, fibrosis leading to myocardial dysfunction. Ifetroban has been shown in animal models to increase survival and cardiac function. And it's a daily oral capsule with safety established in other fibrotic diseases, and over 1,400 clinical trial participants have been dosed. The study design for the phase 2 study is depicted in the cartoon, where it was planned 48 boys greater than 7 years of age in two different disease categories. One is a mild or relatively preserved myocardial function, and one is significantly impaired function. And it was a 1-year trial with randomization, as you can see here, and then open label extension. And so the baseline characteristics are here for the high dose, low dose, and placebo group, which the placebo patients were then offered open label extension after that 1 year. The highlighted portions in pink, mauve, indicate those with significant differences. So as you can see, which this is relevant when we get to the data of the high dose group, was actually older. and also had more prevalence of cardiomyopathy present. And then there were differences because of the cardiomyopathy severity in the medication utilization from a heart standpoint. One of the things about this trial was background therapy, whether it was steroids or approved exon skipping, and all appropriate cardiovascular medications were allowed at the entry of the trial. And so from a safety and a pharmacokinetic perspective, most of the reported events were related to underlying disease. There were no serious adverse events deemed related to the study medication. Some of those events included bruising, which the mechanism of action is similar to aspirin. And so some blood vessel and bruising was on the list. And if you look at the depiction there in the graph, in the adult studies using ifetroban for other indications, boys with Duchenne actually had lower plasma levels, and there was no evidence of significant accumulation. And all subjects who completed 12 months entered into the open label extension. And so these are the data from a cardiac efficacy standpoint, and I'll sort of highlight the different groups. So in the orange, on the far left are individuals in the high-dose ifetroban group, and their LV ejection fraction at 12 months had a slight improvement. Those in the low dose remained stable, and those in the purple are placebo patients. You can see the N equals 6, who had a decrement in function over 1 year's time. Both of these studies, I will mention, utilized propensity and disease score matching from the natural history study, which was funded by the FDA, which is 3 years of sequential cardiac data for patients with Duchenne in a contemporary era. And so if you look at an age match and severity match cohort from the natural history study, which included 18 patients there in the reddish color, over 1 year's time, those patients had a decrement in function of 4% ejection fraction points. And so if you combine the ifetroban placebo group as well as the natural history, you have a decrement in function of almost 4%. And so whether you use the ifetroban cohort or the natural cohort, you had a benefit to function of either 3% or 5%, which was statistically significant. Also, as part of that, cardiac biomarkers over the 12 months of treatment, NT-proBNP showed a reduction, which indicates better from a cardiovascular standpoint, and then cardiac troponin had slight improvement as well. And so in conclusion, for the ifetroban trial, it was well tolerated at doses up to 300 milligrams per day. There was a dose-dependent effect on LVEF, which was observed over this 1 year period of time, and the between-group differences were statistically significant at either 3% or 5%, depending on the placebo comparisons. And the biomarkers did have some improvement at the 1 year mark. And so ifetroban was effective at protecting the heart over this 1 year of treatment. The long-term safety and efficacy data is expected soon, mid-2025, which we are in, and that includes the longer-term follow-up of patients who remained in the open-label extension. And then once that analysis is complete, the regulatory pathway discussions will soon follow. And these are the acknowledgements of all who participated in the trial, including its start and completion. So my second talk relates to Capricor Therapeutics and Deramiocel. These are their forward-looking statements. So many of you are aware of Capricor Therapeutics, and Deramyocel is a cellular therapy, which I appreciate the introduction, which is undergoing review by the FDA for approval of treatment of cardiomyopathy, and that's based on HOPE-2 and then HOPE-2 open label. There's also a HOPE-3 as well. So the compound is administered as IV infusion every 3 months. It's a suspension of cardiosphere-derived cells, which are not stem cells and do not engraft, but the mechanism of action, as we just heard with Amy, is these exosomes release, which has antifibrotic, anti-inflammatory immune modulation, as well as some angiogenic activities. It was granted several designations, as you can see there. And so HOPE-2 was a placebo-controlled study, which was randomized to 12 months of safety and efficacy and had a final enrollment of 20 patients. And then open label extension is multi-year follow-up with 12 patients. It included patients greater than 10 years of age, late ambulatory and non-ambulatory, and an LV ejection fraction greater than 35%. And upper extremity strength with the PUL-2 had to have a score of 2 to 5. And then the secondary endpoints were cardiac parameters with LV ejection fraction. And so the data for cardiac ejection fraction shows long-term stabilization of cardiac function as measured by LVEF. So they, as I mentioned, used a larger comparison group. They were able to match 37 boys in the cohort from Vanderbilt, the natural history study funded by the FDA, which that group had a 5% decrement in ejection fraction. And then if you look at the month 24 data for Deramyocel, you see 1.9 improvement, and up to 48 months, you still have stabilization of myocardial function, which was no different than the start of the trial. So then, starting with patients who had the highest ventricular function at the start, so those with an ejection fraction greater than 45%, a subgroup analysis showed that they actually had greater stabilization over the 4-year trial. So there you see the minus 5% in the comparison cohort, and then you have 3% improvement at month 24, 3% at month 36, and 1% improvement at month 48. And so this is a graph of the PUL-2 data showing there is long-term benefit in slowing the decline of upper limb function. And you can see what's cut off there in blue is year 1, red in year 2, and then green is year 3, and then the purple color is year 4. So the higher slope is consistent with improvement. So the average rate of decline decreases with longer-term treatment. And so the biologics license is currently under review by the FDA for the treatment of cardiomyopathy in patients with DMD, with a PDUFA target date of August of this year. So thank you, Eric.
Thank you, Larry. And then our next speaker is Dr. Aravindhan Veerapandiyan, who's going to discuss the investigational products from Edgewise Therapeutics and Roche.
Right. Good morning, guys. All right. All right. I'm principal investigator of some of their studies, and I don't work for Edgewise. Well, I'll talk about their, and I do consult with them, so that's one of the disclosures. So about Edgewise, they're founded in 2017, and they're focused on developing novel muscle-targeted therapies for muscular dystrophies, including Becker and Duchenne. And they're focused on specifically a concept called muscle injury caused by muscle contraction that's occurring in Duchenne and Becker muscular dystrophy. All right, so this is just to show, we have dystrophin, right? So what does it do is it connects with the proteins that are helpful for muscle fiber contraction, and that by preventing the injury. What happens in dystrophinopathy that we know, there's lack of dystrophin. Because of that, there is mechanical injury. When the muscles contract, there's injury to the muscle fibers. So there are different types of skeletal muscle fibers. The ones that are most susceptible to injury were fast muscle fibers. And the approach that Edgewise took was to actually targeting those, that's contraction-induced injury of those fast muscle fibers. And they have shown in animal models that the drug that they're looking at, which is sevasemten, which is still in the clinical trials, protected those muscle fibers from the contraction-induced muscle damage. And also in some of the initial clinical trials, they had shown decreases in biomarkers such as creatine kinase and others, and also showed some trends towards the functional improvements. All right, I hope that this video plays. Okay, so what you guys see here is to the right, but without the sevasemten, you can see those, as the muscle fibers contract, those damage happening, you see those bubbles coming out. And the second one is with sevasemten, that damage is being prevented. Again, this is in the animal models, and the sevasemten is still in the clinical trials in humans, so just to keep that in mind. All right, so the current clinical trials, so they have both Becker muscular dystrophy programs and Duchenne programs. So we'll talk about on the Becker muscular dystrophy, there's Grand Canyon, which is a pivotal phase 2 study to evaluate the effectiveness and the safety of sevasemten over 18 months. And then there's another study called MESA, which is an ongoing open label extension trial to assess the long-term effects of sevasemten. Then the programs in Duchenne. So there's LYNX, which is it's a 12-week, two-part. First 12 weeks was dose-finding study, and then dose-ranging study, and then you get into a more of a 92-week open-label biomarkers, looking at the safety, how the drug works, pharmacokinetics, and the biomarkers. It's a 92-week open-label extension study. And I think the study is fully enrolled, and we included kids with Duchenne that are ages 4 to 9, that unstable dose of corticosteroids, and there are also a small group of boys with Duchenne who are not on steroids were looked at as well. And again, there's no mutation restrictions, and approved exon skipping therapies were allowed in the trial. And then a FAAC, which is also fully enrolled right now, it is similar study, but on those boys who had already received microdystrophin gene therapy. So just looking into some of the overview of the results of some of these studies. Looking at the Becker studies, from a safety standpoint, the most common side effects reported were dizziness and sleepiness. And again, those were well tolerated in all of those individuals with Becker muscular dystrophy. And because of this dizziness and sleepiness, we advise them to take the medicine before they go to bed. Then just also a little bit of the data from effectiveness standpoint. If you look at the primary endpoint, which is the biomarkers, so there is a change from baseline in both serum creatine kinase and another marker of injury called troponin I. And then also a change in the NSAA score from baseline at 12 months compared to the natural history. The blue bars on the blue bar on the bottom show different papers that we know, different natural history on the Becker muscular dystrophy patients that we know. Compared to that, the ones who are treated with sevasemten, there's change in the NSAA scores in these individuals with Becker muscular dystrophy. All right, some of the next steps. There's Canyon, Grand Canyon. We talked about MESA. The hope is if the data from the Grand Canyon, if positive, could support a marketing application. And the Edgewise Therapeutics plan to actively engage with FDA and EMA on filing strategies for sevasemten and Becker. From a Duchenne standpoint, they expect to announce results from the dose-finding Duchenne study sometime this month. with that, I'm going to move on to the next one. So some of the ones I'm presenting are short and sweet because we don't have a lot of data available, so which is good. How many of you guys in the room know about this Shield DMD study? Other than the industry folks, good. Okay. No, you're fine. Mindy's okay. All right, good. So you will learn about it now. So it is a study targeting both muscles and bones in Duchenne muscular dystrophy. This is probably one of the first studies to actually looking at bones in DMD, bone health in DMD. So the drug that's being looked at is satralizumab. It is an antibody against a receptor called interleukin-6. It acts as the anti-inflammatory drug. It's a phase 2 trial. And what it does is it blocks that, the interleukin-6 receptor. So what do we know is the muscle weakness in Duchenne muscular dystrophy actually causes the bones to be more fragile, osteoporosis. I know we think steroids do cause osteoporosis. No, even without the steroids, the muscle weakness in Duchenne itself can cause osteoporosis, which is worsened by the steroids that we use. The interleukin-6 is a protein that promotes inflammation, and it has been shown that it can cause muscle wasting and bone loss in Duchenne. And there are abnormal interleukin-6 levels in Duchenne, and Roche had looked at these, and they have shown that these levels have been abnormal in Duchenne. So like I said, the satralizumab is an antibody that's designed from human proteins. It blocks that interleukin-6 receptor, and it is injected subcutaneously, which is under the skin, via pre-filled syringes every 4 weeks. So yeah, like I said, we have shown that the Roche had shown that in Duchenne patients, these IL-6 receptor levels were high, and the interleukin levels were altered, leading to the muscle weakness and bone loss as well, and that's the target for the satralizumab drug. So it's not the first time this drug is being used. So this drug has been used in numerous a lot of patients in the neurology space as an anti-inflammatory drug. It's approved in 91 countries for, sorry, excuse me, for, this is what happens if you just be up late nights in Vegas. Oh, thank you. So it's approved in 91 countries with for a disease called NMO, neuromyelitis optica. It's an inflammatory disease affecting the brain and the spinal cord. And it is under clinical investigation for other rare neurological and eye diseases. The data that they have so far has been well tolerated with long-term data in more than 5,000 patients over 9 years, including children and adults. These are the most common adverse reactions, as you could see here. Or headache, joint pain, injection site reactions. Like I said, these are subcutaneous injections. The study is actually, the Shield DMD is a phase 2 open-label clinical trial studying the impact of this satralizumab in muscles and bones in DMD boys aged 8 to 17. The study is currently recruiting in Italy, Poland, Spain, and the US. We have 7 sites open in the United States right now. And like I said, it is a 2-year-long open-label study. There's, as any other trial, they have screening and baseline phase, and then you see the actual study phase. You get the primary objective is to look at the bones, the bone mineral density, but we're also looking at the muscle function as well as exploratory objectives. And as any other clinical trials, these individuals are undergoing DEXA scans and other physical therapy assessments to look at the muscle function as well. All right, and who can join this study? And of course, anyone with Duchenne muscular dystrophy is age of 8 and older, but under 18, and have to take daily oral steroids for at least 12 months. As you could see, there's 2 groups with little bit slightly minor differences in these groups. The key here I want to highlight here is they are looking at kids in individuals who are treated with gene therapy and exon skipping agents. However, while the kids who are taking vamorolone and givinostat will be excluded during the first year of the study, but after that, they can be taken. With that, thank you all. I'm sorry for the voice stuff.
And then we're going to kind of go to an open Q&A, so I'm going to invite both of our other speakers to join us back on stage. And then, like some of the other sessions, we have mics in each one of the rows. So if you have questions for any of our panelists or about the presentations they gave, please join us at the mics. And then while we wait for questions, I do have, I think, just a few as well for all of you. So I do think maybe, Panna, to start with you, and good up having also a cardiologist on stage. So when you were talking about some of the data from Edgewise, you talked about troponin, and I wonder, with the audience that probably heard of, we've talked about troponins at different times with different ones, so can we talk maybe cardiac versus skeletal and what that was kind of measuring and looking at, just to make sure.
Sure. It was actually looking at the marker that's actually specific for the muscle, not the cardiac troponin.
Just we can measure, we have different troponins that we can measure, so just want to make sure there's clarity around that when we're discussing. And I think, too, with this, a little bit different, that kind of expectation, even though the trials for this are going to have very specific recruitment criteria, unlike maybe some of our exon skipping therapies or gene therapies, that there's going to be less potential restrictions for who could use these therapies if they got to approval. Correct?
Sorry, I wasn't paying attention to the question.
We're not expecting the kind of mutation restrictions that we
So
have.
I was up until like 4 a.m., okay, so. Sorry,
yeah. Just that we expect this to be more broadly applicable to the Duchenne population, not having some of the mutation restrictions we see with other therapies that we talked about in the conference.
Right. So I think that's a goal for all of these add-on, all of these downstream therapies. What we say doesn't target the dystrophin to potentially be used as a combination or add-on therapies.
And I think it goes to the target and how you're sort of planning your outcome measures. So if you're looking at the heart, for a lot of the studies, there's conversation about enrolling ambulatory versus and non-ambulatory, because you're looking at the heart across the lifespan, and so they have the possibility of being more open to inclusion criteria.
And then maybe Larry, for you, and on that kind of, you talked a little bit about the propensity score matching, and I think sometimes we talk with families about the use of external controls. Can we just maybe talk a little bit about how that's being used, I think, in both these trials to help us maybe get to some answers when we don't have as high-powered studies?
Yeah, so if you were to look at, I don't know, pick your favorite cholesterol drug, for example, and look at the adult data on reducing cardiovascular risk and heart attack. Those studies are going to have tens of thousands of patients, and they're looking at risk reduction over someone's lifespan. Or if you're looking at an intervention, of those 10,000, you may have 5,000, 2,000 patients who are not receiving the therapy of interest. I don't know if you've realized, but Duchenne is a progressive disease. That's a little bit tongue-in-cheek. And so a lot of companies recognize, as well as clinicians doing the clinical trials, that there is some element of ethics surrounding a progressive disease, and I won't say tying up a patient, but putting a patient in a placebo arm for an extended period of time, where even over 1 year or 2 year time period, that there can be progression of disease in that time. And if you are in a trial that keeps you there, you also don't have options for other trials, but you may be seeing a change in your disease course. So, and then there's the whole biostatistics part of a meaningful outcome measure that is statistically significant, meaning that it is more likely that the therapy resulted in the outcome than by chance alone. And so I was part of a group that applied for and was funded 5 years ago, funded by the FDA, and it's the largest natural history study in cardiac outcomes for Duchenne. And we enrolled, I think it's 185 patients was the final count, over a 3-year period of time of yearly cardiac MRI, a few skeletal muscle testing, blood biomarkers, and then some investigational biomarkers. And so what that allows companies to do, which was part of the reason we wanted to do it, is in this day and age, now, patients getting gene therapy were not included in that cohort, but it's a contemporary group of the 2020s who are on steroids, who are on cardiac medication, so forth and so on. So it is current day, and it is probably the most complete data set from a cardiac standpoint that exists. And so you can actually go in and you can say, you know, I need patients who are between the ages of 10 and 15 who are this size, you know, this height, weight, this range, and that maybe are on these therapies. And so that gives you a sample of patients that have had annual testing in a very rigorous way, and you can see how that was able to supplement 2 studies so that both studies then achieved statistical significance because you had more placebo or untreated patients than you did treated patients.
Thank you. Down here in the middle.
So I have comments about the trial study design, and in particular, Veerapandiyan that Cumberland is sponsoring, in the respect that they are providing cardiac MRI data to clinics. And I think that where this is possible, this is exceptionally important to patients and families so they don't have to repeat MRI, especially as our participants get older, access to MRI becomes more difficult, and I think that was a great add-on to the trial, allowing that information to be shared. I don't think that it was in a manner that was problematic for the trial, but it's certainly from a patient and family standpoint that was well appreciated. Thank you.
Yeah, so, and it really evolved the conversations around the protocols. So all of us who are engaged in the natural history study agreed clinically we were going to adopt the same protocol for our clinical MRIs that was being used for the research MRIs, so that and that was intentional. So we haven't done analysis on the comparison of the local interpretation versus the core lab interpretation. But the data that was presented is all of the core lab data. But we know MRI is very precise even among readers. And so I don't think there would be significant variability in what your center would have said the result of the trial was versus what ultimately ends up being the interpretation.
Yeah, just to add to that, I think we have some industry folks in the room. I think this is extremely important to keep in mind. If we can try to come up with the protocols for cardiac MRIs or other tests that mirror what we do in the clinics, would be extremely helpful rather than coming up with the own protocol with the vendor that you work with. Just a plug for that. Again, that's, for a site, it's helpful. It's also helpful for the families as well, so they get both together.
Yeah, and we actually, in May, we had a roundtable with a number of the drug companies. PPMD has a Duchenne Drug Development Roundtable, and we talked about data sharing, and Dr. John Soslow from Vanderbilt was there to kind of share some of the process they did in this protocol to ensure that families could get some of their MRI data back quickly to try and reduce that burden, because we, of course, don't want patients to have to undergo multiple cardiac MRIs with contrast in a given year. And so it was something I think the companies were really receptive to in exploring some of these ways that we can get some of that data back to patients quickly.
Hi, everyone. Thank you so much for the presentation. I feel very encouraged. This is Sui Xiatian. I'm from Cincinnati Children's. I'm a child neurologist. I have a question particular for the two potential cardiomyopathy drugs. I know for the trial development, we have to look at a relative later stage, of the disease and to assess the cardiomyopathy part. I was thinking ahead, since it's addressing more mechanism related with the disease progression, is it possible we can use it earlier? And will possible FDA to, consider that to make it more applicable?
Yeah, I would agree, and I think that's why I think the design of both of the trials would, at least in my opinion, seem to suggest that, because a large portion of the patients had an ejection fraction greater than 45%, which most of us would say that would be pretty mild cardiomyopathy. And so there were a significant number of patients that were in that population. And so I think the results are probably driven mostly by those patients than those who were in the 35 to 45 category.
Is it possible even before LVEF change?
Oh, sure. There are a number, and if you saw the average ejection fraction for the study, it was in the 50s. Mm-hmm. So again, there were a number of patients that had normal ejection fractions that were in the study.
Thank you.
And then over here on the right.
Yeah. Hi, everyone. It's Niyati Prasad I'm the head of clinical development at Grunenthal. Thanks for a great session. I had a question for Arvind, actually. So Sevacem-10, that did cause AEs of dizziness and sleepiness. So is the assumption correct that it is penetrating blood-brain barrier, and therefore you will have a protective effect, or you will have an effect on behavioral disturbances in the children or in the boys?
So just to say, for the sleepiness and dizziness, right, that's just a term that we use. When you talk to from the clinical experience, when you talk to to the individuals that are taking it, they really can't explain what they feel. It's not actual dizziness, it's not vertigo, they just can't explain really, so we have to come up with the term as a dizziness. Now, I don't think we have looked at behaviors on we don't know if it actually crosses blood-brain barrier, but it's a reasonable assumption, but we haven't looked at the cognitive or behavioral effectiveness of this drug particularly.
Sure. Thank you. Thanks very much.
Brian?
So there's an online question related to Edgewise, and wondering, the person wants to know about the links and FAAC data and a timeline when that information will be available.
So I think, as mentioned in the slide, they're trying to release the initial dose-finding data in June. So hopefully in the next couple of weeks, we should be able to. And the Edgewise folks are here too. They can add more if they want to, but I think that's the plan.
Thank you. Over here on the left.
Hi, this is Ilaria from Parent Project Italy. I think it's very good that we are progressing with more and more new drugs and new clinical trials, because we are still to find the best cure, the best treatment for our patients. I was wondering, are you experiencing or are you expecting some, with all the drugs you have, all the clinical trials, some delays in the recruitment? Because this would be a delay in finding something that works better, I think.
That's a great question. Everyone, as you could see, looking at same age groups, 4 to 7, ambulatory boys, and restrictions. Definitely there is challenges in the recruitment, at least in the United States, and that's why I think from a global studies would help. And I think when you come to the United States, have the expectations of, that there is going to be delays in recruitment, challenges in recruitment.
Down here in the middle.
Hi, I'm Leslie, parent of a 16-year-old, and I'm curious about the FDA approval, especially for the cardiac medicine that's coming close. August was the date. Well, a couple of questions. Is that going to be slowed down by some of the changes in support from the current administration? And then what do we do when it's approved with our cardiologist to get our boys started as soon as possible?
So to quote Eric, it's about relationships. And so PPMD embarks on establishing relationships whenever there is a change in leadership, particularly at the FDA. So I have no idea what the road looks like, given that I have no idea what the larger road looks like over the last 6 months of our journey here in the United States. So I think there are a lot of unknowns, but you have the largest advocacy group who is active in establishing relationships and sort of taking up the mantle with companies to help navigate the uncertainties. And then I think what follows is going through the FDA process, and then like other candidate drugs, once there is an approval, then the conversations with your local cardiologist to say, well, here's the data, help me entertain this, and then kind of go from there. And the companies are here and certainly available to explain what their specific process is planned to look like.
And so that August date is approval, or that's sort of the beginning of approval?
I think.
So yeah, that's the PDUFA date, so that's when we'll have a decision. But yeah, Mark, if you want to.
Yes, hi, Mark Awadala with Capricor Therapeutics. Yes, we are currently under FDA review. There really has been no quote-unquote slowdown during the administration. Everything is on track for a PDUFA target date of August 31st. So that is, we are hopeful that is the date we will get approval.
And then just a quick question. So should we talk to our cardiologist now, or do we wait till it's approved?
I think that's a great question. I think there are conversations already happening from the sponsor side and talking to the sites and getting ready for the commercialization. And I think it's always good to start these conversations early with the cardiologist as well. Yeah.
Thank you.
Well, so what I would say, I would go back and say there's lots of things that we know that sort of already work, or that most of us would do or should do. And so I would say this is an opportunity to just take a step back and say, with your team, and say, okay, how is my heart, and what are we on currently, and what opportunities do we have to make things better? And you want to get all that sorted out before you throw something else in the mix. So I would have that conversation with your cardiologist and say, all right, are we doing everything that we can? Have we optimized dosing? Do we need any updated testing to really decide where we are? And then embark, just like you said.
Great, thank you.
Yeah, sure.
I also think just is helpful for families with some of the expectation setting, and this is kind of our lived experience that we had with even our more recent approvals with Agamree and Duvizet, is that when we have that approval and we're hopeful that we have a positive outcome, it is it's not going to be the next day, but starting those conversations early with your care team too, so they know that you have that interest and you can start that conversation around, is this drug appropriate for me? What do I need to be prepared? How do I start getting some of those conversations about insurance, which I know we've talked a little bit about. So prepping with your care team is great, but just as also just an expectation of we will try to keep you as up to date of when these are available as well. So over here.
Hi, good morning. Thank you very much for presenting that information. And I do have a question that I'd like to direct towards the Capricor group. for that, my kiddo is participating in the HOPE-3 trial, and we're not too far away from being in the open label component. There have been, understandably, some specific avenues for how we can deal with the cardiac MRI and not necessarily having contrast, whereas our cardiologists would like to see contrast involved with the cardiac MRI. In the open label study, will that potentially be a little more available to work with the contrast and maybe, work with the cardiac contrast involvement so we can share the data with his regular cardiologist? If this is appropriate to answer.
So this is also, I think, we're about to go to break to our pharma forum, which I think is a great opportunity to connect with the Capricor team to kind of have that direct conversation.
Absolutely. Okay.
So I'm going to give a little, because there's a couple different places that as we break here that you guys are going to be able to go. But first of all, I'd like to thank all of our panelists for joining us today.